Hello, I'm Katie Thomas. I'm a research fellow in cardiovascular medicine. My guest today is Professor Sir Rory Collins. He is a BHF Professor of Medicine and Epidemiology and the head of the Nuffield Department of Population Health at the University of Oxford. Good morning, Professor Collins. Thank you for joining us for the podcast.
Thanks very much for the invitation.
Professor Collins, a large amount of science fails to translate from basic science to clinical practice. Do you think that poor experimental design and statistical analysis could be partly responsible for this?
It's important to do a good experiment, but it's also important to do that experiment well. And I think one of the concerns that we've seen, not just in basic science, but in clinical research, is a failure to replicate study results. And the question there is whether better study design would ensure that the results that we think are correct really are correct.
A fundamental problem we face in basic science is applying statistics because there's a small number of units we can use. How valid is the application of statistical analysis in basic science?
The important thing with the use of statistical methods in analysing data is to use the right method for that particular purpose. So where you have very large amounts of data, where you have normal distribution, then one can use standard methods. If, however, one doesn't have normal distributions or have very small numbers, then one has to use different methods. It's, again, horses for courses. Use the right methodology, get the right kind of statistical advice to analyse the particular kinds of data you have. And I think it's not just about getting the result right, but it's also about getting as much information out of the data that is generated. Having spent a small amount of time in a lab, I saw the huge amount of work that goes into generating those data. But my feeling was that more sophisticated statistical analysis methods would have got more out of all of that hard work.
How important is the use of power calculations in basic science?
A lot of research done in the laboratory is hypothesis generating rather than hypothesis testing. And typically when we think about power calculations, we have in mind what sort of effect we're trying to detect, and then we can say how big the study needs to be. It's a little bit more difficult when one's generating hypotheses, but even so, I think it's worthwhile thinking about what's plausible and then designing the study to pick up plausible effects so that one doesn't rule out hypotheses on the basis of studies that were of inadequate size to detect the kinds of effects that might be important.
How important is blinding and randomization in trials?
So in clinical trials, we do randomization in order that we can compare like with like. And the same is important not just for humans in clinical trials, but if we're comparing groups of cells, groups of animals, we want to know that they differ only randomly from each other in terms of all their underlying characteristics, so that if we see differences, we know that they're real and not due to some bias in the comparison between the different groups. The same thing is true with blinding. We're trying to avoid bias in the ascertainment of whatever is the outcome of interest. And again, we want to be sure that we're comparing like with like. We want to be sure that when we see something in one group, we would see it in the other group, and it's not just that we see it because we know which group they're in. So in both cases, we're trying to avoid bias, either between the different groups in terms of their underlying characteristics, or with blinding in terms of the ascertainment of the outcomes of interest.
From a trialist perspective, what are the most important steps for the translation of a new experimental basic model into clinical practice?
Well, the basic science is generating a hypothesis. We hope it's true. We would like it to take it right the way through to identifying a safe and effective treatment. And there are clearly a number of steps there. What dose should we be using? And obviously that moves from basic science into the early clinical studies. Can we get any clues as to whether the treatment is likely to be effective? And recently people have started to use genetic epidemiology, so-called Mendelian randomization, to determine whether intervening on a particular pathway has effects on outcomes that might predict what the clinical trial would show, and also using that to see if there might be some off-target safety effects. We then need to go into early stage clinical trials to see whether we do have effects on intermediates And again, the genetic epidemiology can help to tell us whether effects on those intermediates are likely to result in causal changes in clinical outcomes. And then finally, we do the large-scale trials, but there are a large number of steps in between that can help us to ensure that when we do get to the large-scale trial, we're using the right dose, we're looking for the effect of an intermediate that's likely to change clinical outcome, and that we can perhaps be forewarned about potential off-target effects to assess in those studies.
Thank you, Professor Collins.
Thank you.